Alrighty, good afternoon, everyone. We will go ahead and get started. I did launch a poll, so please, you should be able to view that and complete that. So please start completing that as we go through our welcome and introduction. So good afternoon, and thank you for joining us. My name is Lakin Ethan, and I'm a program manager at the University of Pittsburgh Program Evaluation and Research Unit. For about the past year now, Peru and Vital Strategies have been collaborating to improve knowledge of harm reduction as a strategy for reducing overdose deaths. In addition to supporting coalitions to build capacity and implement harm reduction initiatives, we are working to provide opportunities for coalitions across Pennsylvania to learn about harm reduction and its role in reducing overdose deaths and improving the health and safety of individuals with substance use disorder. Our first webinar, How to Work Inclusively with People Who Use Drugs, is the first in a 7-part series. Today's webinar aims to discuss how to include people who use drugs in planning, implementing, and leading drug-related initiatives. Before we get into today's presentation, just want to remind folks of a few housekeeping items. So first, the webinar is being recorded. It will also be made available on overdosefreepa.pitt.edu following today's presentation. Please stay muted. If you do have questions, please place them in the chat. Myself and our folks from Vital Strategies will be monitoring the chat throughout the presentation. Additionally, please fill out the evaluation. I'll pop the evaluation link into the chat periodically throughout the presentation, especially for folks who may need to jump off a little bit early. So please fill out that evaluation, as it will help us as we plan the rest of our webinar series. Alrighty. So first, our webinar objectives. I will keep these up. Oops, sorry. I will keep these up as we go through our bios here very quickly. As we go through our bios here. So with those housekeeping items in place, I am pleased to introduce our 2 presenters for today's webinar, Brooke Feldman and Gus Grannon. Brooke is a widely recognized speaker, advocate, and consultant, and a writer who brings a wealth of experience and knowledge when it comes to issues of drug user health, addiction, recovery, social justice, and improving behavioral healthcare systems. Prior to her current role as the Philadelphia Center Manager of Clean Slate Outpatient Addiction Medicine, Brooke served for several years as a national consultant focused on behavioral health systems transformation. For 10 years leading up to her consulting work, Brooke served in Philadelphia's behavioral health system in a variety of settings, including a recovery residence, addiction treatment center, recovery community organization, and the City of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. Brooke also currently serves on the board of Angels in Motion, a street-based harm reduction and recovery support organization. In that capacity, Brooke has helped grow AIM's citywide mobile syringe service program. Gus Grannon has been actively engaged in many forms of harm reduction for almost 2 decades. He trained with Dan Bigg at Chicago Recovery Alliance in injection techniques, overdose prevention and reversal, wound care and treatment, and substance use treatment modalities. He has worked in Camden, New Jersey, Philadelphia, and is currently the harm reduction and data coordinator for Project SAFE. He trains the spectrum of those engaged in the clinical and social care of drug users and advocated for the wisdom and agency of active users in every academic, clinical, nonprofit, and governmental level in all 3 cities. He has presented at the Drug Policy Alliance, Harm Reduction Coalition, NASEN, Desiree, and other national, international, and local conferences. And he has been an early advocate of safer consumption spaces and safer supply as ways to address many harms around every mode of drug use. We are very excited to have Brooke and Gus with us today, so please join me in welcoming Brooke Feldman and Gus Grannon. And I will go ahead and stop my share, and Brooke, you are good to share your screen.
All right, thank you. You always become aware of how obnoxiously long your bio is when you have to listen to somebody read it. I need to shorten that. All right. All right, thumbs up if you can see the screen. All right. So my name is Brooke Feldman, and Gus is here as well. You heard more about us than you wanted to know, at least for me, but we're excited to be here. I was saying, as we got everything loaded up, that in the era of COVID, presentations are just totally different. I'm somebody who feeds off the energy in the room, but right now it's just me in a room, and you all are all on my screen. So feel free to give emphatic head nods. Definitely use the chat feature. We have folks monitoring the chat. It's too hard for me to talk and monitor the chat. I took out my gum also, so I don't have to try to chew gum as well. But we want you to be interactive, put questions, comments in the chat. We're going to rock out. If I make a really bad joke, just smile anyway, because that keeps me going, and I appreciate it. So it's awesome to get to kind of kick off what's going to be an amazing series talking about harm reduction. It sounds like many of you really wanted to hear more about harm reduction and how to really integrate into the work that you're doing. And so it's always an honor to be first. It's also like if you suck, you just get to claim that I was first and you get some forgiveness for that. So I appreciate it. So I wanted to kind of just start off with defining harm reduction. We go through like these buzzwords, right? And there is this hot topic of the day and the buzzwords of the day. I grew up sort of professionally in the era of recovery-oriented systems of care, and that was a ROSC, because we make everything an acronym in our field. And so we'll often hear these buzzwords, and we're like, what does that even mean? And so when we talk about harm reduction, we're kind of talking about two things. And for me, it's important to always go back to bringing us to harm reduction with the big H and the big R, which is this broader social political movement that's really rooted in other movements such as women's reproductive rights, the AIDS crisis, civil rights, really looking to dismantle racism and white supremacy. And so when we talk about harm reduction, it's always important to remember that we're talking about this larger social movement. And if you're like, what the hell are you talking about? We don't have time to go very deep into it today, but I encourage you to really read more about where harm reduction came from. And it's fitting that the first webinar in this series is about how do you involve and be led by people who actually use drugs. Because harm reduction as a movement was really the people who were most impacted by harmful systems and by not getting their needs met, decided we're going to take matters into our own hands and really dismantle these harmful systems and take care of each other. And so that's really the broader framework. And I think when it comes to what we often hear talked about when we hear harm reduction, we're talking about that little h and that little r, and really the interventions and practices that make up harm reduction. So we'll get into some examples of that, but I always want to start off there and encourage anybody who doesn't know really our history and where we come from to kind of take the time to learn about it. And so to define harm reduction, the little h, little r is that we're talking about a set of practical strategies and ideas that are aimed at reducing the negative consequences associated with drug use. So that's pretty simple, and we'll talk about concretely what that looks like. But again, remembering always that we're part of this larger movement, a social justice movement that really centers and affirms that people who are most impacted by drug policy, by drug use, and by the harms that some of the systems we interact with cause, that we are always to be led by those folks. I very openly identify as a person in recovery. And for me, just because I could not successfully ever moderate my use of most drugs, it means, that I don't use a lot of drugs. But to use my experience as someone who once did use drugs, and to say that, if we get Brooke's opinion on this, that means we involve people with lived experience. That would be a big mistake. The landscape was very different when I was using drugs. I love me some pills, and a good example is I could buy pills from the unregulated market and pretty much know that I was going to get what I was buying. Is nothing like that today. And I was talking to Gus over the weekend as we went through our presentation. I'm very much in touch with that. If I was somebody who uses drugs in today's age, I'd likely be dead because I would take any pill that somebody handed me or that I could buy. And we're really existing in a world right now where we have tons of counterfeit pills that have flooded the market. And it's very dangerous to be someone who uses pills, for pleasure, numbing, escaping, whatever it is. And so when we talk about the little h and little r, what those services are, this is a long list of those services. And many of them you're probably familiar with. And I imagine many of these services you're already doing, in some fashion. So outreach and engagement, I very much got to see how we went from expecting people to come to us for services to really starting to say, wait a minute, maybe we need to go out to where people are and actually engage them and talk to them and meet people where they're at. And so I think the idea of meeting people where they're at in some ways started with physically, like getting the hell out of the building and going out to where people who use drugs are, talking to them, building relationships with them, finding out what that person's needs are versus what we think the needs are, and really, relationship building. Also, syringe service programs, I think many people are familiar, although in our great state of Pennsylvania, they remain illegal. I would not sleep well in my little advocate heart if I didn't mention that we currently have legislation at the state level to once and for all decriminalize syringe service programs. We know that they work to reduce many harms, and I'm hopeful that if you have a little advocate heart too, you will find a way to get involved in telling our elected officials we need, to decriminalize these programs. Naloxone training and distribution. I've been in many systems where as long as there's naloxone distribution, it's like we do harm reduction. We got it. We can rest easy. We're harm reductionists. It's huge. We have a medication that essentially makes overdose deaths preventable or drug poisoning, fentanyl related drug poisoning deaths preventable. And so getting naloxone out into the community is huge, certainly is harm reduction, but I often challenge folks, don't stop there. That just throwing some naloxone out into the community is far from what is needed, both at an individual and at a systems level when it comes to harm reduction. The other thing is low threshold access to medications used to treat opioid use disorder. In my city of Philadelphia, at least, there was about 9,602 hoops that you'd have to jump through in order to get access to medications to save your life. It reminds me again of the roots of harm reduction and the AIDS crisis, where folks realize like if we sit around and wait for people to give us the medication that will save our lives, we're going to be in a lot of trouble. And there were a lot of amazing things done to not only get medication into the hands of people who needed it, but also to really push the government to move faster in getting the medication out to the masses. And so when we think about harm reduction, thinking about access to low threshold medications to treat OUD, removing the 9,000, and I forget the exact number I said, but all those hoops that people had to jump through, and not really demanding all these different expectations and requirements in order for somebody to get the medication. Even things like prior authorizations, I think often in my work that if people who sell drugs required a prior auth in order to get cocaine or methamphetamine or fentanyl, we'd live in a different world. But no person who sells drugs has ever said when somebody came to purchase those drugs, wait a minute, I need to fill out a prior authorization that we may hear back, a yes or no in 24 to 48 hours, just sit tight. But we often, we often had a system for accessing medications that have worked like that. Warm handoff programs are huge. I always caution folks though. I don't know about how many people of how many people on here have actually used drugs themselves or would identify as in recovery. And if I was in the room, I'd ask you if you felt comfortable to raise your hand, but I only see like 5 boxes, so it wouldn't work on Zoom anyway. I know for me though, like if I overdosed and just kind of like, woke up and had no idea what happened, the last thing I want is any services that you're offering me. I'm trying to figure out how I can go get well. I'm trying to figure out first, like, what happened, how I can go get well. And so a mistake of warm handoff programs and how you can tell that they may not have been informed by people who use drugs is when there's this expectation that, like, the person right then and there is going to want some kind of services or support. And then if the person doesn't want what you have to offer, they kind of like, no, well, and so warm handoff programs absolutely need to be informed by people who use drugs in order to be effective. The idea of housing first, hopefully that's not a new term, but the idea that, we are not demanding people meet these expectations in order to receive housing. I think that is really hard to find wellness, whether you're a person who uses drugs or not, if you have nowhere to live, right? And I know social determinants of health is another sort of buzz topic, right? Especially if you're in the center of excellence crowd in the Zoom room. And housing is like huge. And, when we talk about social determinants of health, and so really moving away from this idea that a person has to first demonstrate that they're worthy or ready or deserving of housing before they get housing. Low threshold recovery housing, I think we're still making progress in recovery housing, not demanding that a person is not using the evidence-based medications we know work to prevent overdose death when it comes to opioids. I know in my area, there's still some recovery house holdouts that very much see the use of bupe or methadone as still using or not really in recovery. And then what happens is for folks that are using these medications to save their own lives, when they knock on the recovery house door, they're told, sorry, we can't take you. And so accepting people that are using the medications that we know work is certainly part of low threshold housing, but also not requiring abstinence. And I'm someone who was raised up and indoctrinated into like abstinence is the way, the only way is jails, institutions, or death if I don't practice total abstinence. I got my first basic text and big book at the age of 13. And so when I say I was raised up in it, I mean I was literally raised up in it. And the idea that people could live somewhere without, who are still using, like without demanding abstinence, it went against like everything that I had been taught about recovery, about recovery housing. But we know that we've seen actually from research that demonstrates that people who have access to housing before they are abstinent or without abstinence actually do just as well as those who are required to be abstinent in order to go into the recovery house. And somebody smarter than me remind me to find that research from New York that demonstrated that. So really, one, just kind of, understanding that people who use medications to treat OUD should have a place to live, and that is discrimination to say they can't live in a recovery house. And then two, thinking about how do we create housing opportunities for people who don't have abstinence as the goal. And then the last two things, supervised consumption, hot topic in Philly. I'm sure some of you have heard about Safe House, but the idea that, we need safe places for people who use drugs to use drugs and to not die. The idea that because someone is using drugs that they deserve to die really needs to be abolished. And then safe supply, which is often the most controversial of all, especially for those of us raised up in the abstinence is, the only way and the holy grail. The idea that people, who are dying right now are dying not so much from overdose deaths, which we continue to call them, but from drug poisoning deaths. And when you look at how the death rate has risen, it's really the introduction of fentanyl into the drug supply that has led to the increase in deaths. And so if people have access to a safe supply, then they know what they're using, how much they're using, and are able to manage their use differently. I feel like I just talked a whole lot without taking a breath. Gus, I don't know if you want to add anything to this slide about services. Is Gus frozen or did I talk him into paralysis?
It looks like we lost Gus.
We lost Gus. He's been abandoned, everybody. This never happens. I have never been abandoned in a live presentation. So I'll keep it moving. I'm sure Gus will come back. Just another fun aspect of presentations in the world of Zoom. This is Gus's slide, and so I'm going to try to talk in my Gus voice. It's important to remember. I can't do it. Yeah, hopefully Gus does come back because he really is just very experienced and knowledgeable in where harm reduction practices have come from. And the reality is that our most effective harm reduction practices, from naloxone distribution to supervised consumption, have come from people who use drugs. They actually did not come from somebody sitting, in a county or state government building developing policy. Our best harm reduction practices have actually come from people who use drugs themselves. And that's really key to remember. There's a few things that I'll really emphasize because it's the whole point of the webinar today. We're talking about why it's important to include people who use drugs in all decision making. And if nothing else gets you to thinking, wow, I should really talk to people who use drugs to find out what their ideas are, or if they think my great idea is really a great idea. The reality that anything we think of when it comes to harm reduction is something that came from people who use drugs. That should really stick with us. It definitely wasn't someone who sat in a room and thought of these things. Gus talks a lot about how harm reduction has really great public health outcomes, but that we can't organize harm reduction around public health alone. People who use drugs are not sitting around having conversations about public health outcomes, unless I just hung out with a different crowd when I was using drugs, but we weren't really thinking about what the public health experts had to say. We were more so thinking about how do we not die and support each other, have a sense of community, a sense of belonging, and have what it is we need to survive and even thrive. So harm reduction is low threshold. And so what we mean by that, again, that typically to access services, you really have had to meet you can't see my hands unless I get really high, but you had to meet this high bar in order to engage. It's you had to kind of demonstrate that you were ready, that you've had enough. Hopefully no one still uses this term, but that you hit rock bottom in order to access services. And often we expect this commitment to abstinence. And it's kind of for people who aren't there or who aren't there yet, when it comes to abstinence, there's not a whole lot available. And so what ends up happening is that people who are at highest risk, which is people who are currently using drugs, end up really marginalized and left out of a lot of the services we have to offer. Sometimes, where we see some progress, but far from enough, is there might be this position of, okay, you don't have to be ready to be abstinent yet, but our expectation is eventually abstinence is your goal. And so even if the person isn't required to immediately be abstinent in order to engage in services, you can tell in the culture, you can tell in the approach and the philosophy that the goal is ultimately total abstinence. And for people who don't have that goal, it makes whatever services you're offering feel pretty irrelevant to them. Engagement in clinical services is another thing. So where I work, my day job, I should have offered disclaimer that everything I say today is Brooke Feldman's opinion and doesn't represent the view of my employer or anyone else. But where I do work, a place called Clean Slate, and some of you may actually be on the webinar who work at Clean Slate, people aren't required to engage in counseling in order to receive BUTE. Too many places will say you can receive this medication if you do this, and this is often counseling. I know for a lot of the folks that I serve, they could run counseling groups. They've been in more counseling than most people will ever even think about in their lives. And the idea that someone has to engage in counseling in order to get medication is just a huge barrier and is not really meeting people where they're at. Again, I go back to people who sell drugs, right? If I went to go cop some coke and the person I was buying drugs off of said, you can get this cocaine, Brooke, if you'll go talk to somebody for 50 minutes. I would find someone else who sells drugs if I wasn't looking to talk to somebody. So we really have to lower the bar for engagement in services, and that includes individual and group therapy. This is a big point too. Did we get Gus back yet? Because I'm starting to run out of breath. No, Gus? Oh man. So a big thing is, I've worked in a number of different roles and worked for programs that received federal funding, state funding, county funding. And often, when these programs are written, number one is usually like a grant writer for an organization that wrote this whole idea of what the program is going to be. Maybe there was some involvement of the staff, maybe not. And the goal is usually to please the funder, to say, we're going to do these amazing things if you give us this money that we know you want us to do, right? But sometimes the things that we think about, in fact, maybe a lot of the times, the things that we think are good ideas initially aren't really what people want. And we might think, a good example I have is this. So when COVID hit, I would talk to people about not sharing cigarettes, and I would try to educate folks. I'd say, listen, like, sharing cigarettes is a surefire way to spread COVID. And people will kind of just like humor me and then share their cigarette, right? If any of you are smokers or former smokers, I don't know about you all, but if I didn't have a cigarette and somebody offered me a short, I was going to smoke that no matter what kind of pandemic illness I'd get, right? And so I realized that having these conversations and trying to educate people about the risks of sharing cigarettes was going nowhere, because they would just pass it right in front of me. And so I thought to myself, like, what can we do about this? And I found on Amazon, there were these little plastic tips that you can put on a cigarette. And I guess it's to catch the tar when you take, when you inhale it. And I was like, oh, I have a great idea. Didn't talk to anybody who uses
Should be
drugs.
unmuted.
Didn't talk to
Okay.
anybody who smokes. And I was like, I'm going to buy these little plastic tips for the cigarettes. And this will help people not spread COVID, because they're going to use these tips and put it on their cigarette. And so they came, it took like a week, because Amazon's all jacked up now during COVID, got these little tips to put on the cigarettes. And, nobody wanted to use them. People were confused. They're like, what the hell is this? And I was like, it's kind of devastated. I was like, this is a great idea, guys. Like, you can share cigarettes and not get COVID. But it was an idea I had. It wasn't an idea that people who share cigarettes had. They weren't like, hey, Brooke, can you help us share cigarettes more safely? It just wasn't their concern. And so when we talk about programmatic expectations being out of alignment to person's needs, sometimes the things that we think are a good idea or what the person needs just aren't what they want or what they need. And so I see we have Gus back, which is great, because I need a sip of water. Welcome
Sorry
back,
about
Gus.
that. Hopefully I got my network problems ironed out. I apologize to everybody.
No, you haven't lived unless that happens once in your life during the pandemic.
Yeah, right.
So I know, Gus, we talked about this slide, and I know you had some thoughts about kind of what a program expects from a person being not exactly what the person may want or need. I don't know if you've caught your breath enough coming back to add any thoughts here before we move to the next slide.
Yeah, I mean, it is, we talked earlier about the definition of harm reduction, and the ones that we presented are the typically sort of functional ones that a lot of people use. I think it's also useful to keep in mind sort of the definition of harm reduction I was brought up in, which really was just meet people where they are. A big part of meeting harm reduction, of presenting harm reduction, is to remove as many barriers as possible, whether it is to treatment, whether it is to health interventions. It's really important. A really important skill to develop is the skill to empathize, the skill to put yourself in the place of someone who you may or may not have a good idea of where they're coming from. And like it says on this slide, that programmatic expectations have been out of alignment with persons' needs. That happens when the people who are trying to access services do not have input into how those services are delivered. And I think that's kind of going to be a recurrent theme throughout this presentation. So I will go on about the history of community-based naloxone distribution. It started in the late 90s, early 2000s, really in two places in the US. It started in San Francisco to a certain extent, but the part I'm familiar with is that it started in Chicago with Chicago Recovery Alliance, and specifically with Dan Bigg. Dan was one of the founders of CRA, and even in the 90s was getting tired of watching people he worked with and people he loved die. One of the other founders of CRA died of an overdose early on, and that really was one of the motivating factors for Dan to kind of think outside of what was the box at that time, which was every time that you use a bag of heroin, you're taking your life in your hands. And he sort of refused to accept that as given and tried to find a way to address it. And the way that he found was naloxone, which is the generic form of Narcan, that is an opioid antagonist. And I don't know how many folks in this presentation are strictly familiar with naloxone. I'm going to gloss over it. If anybody is confused, please drop a note in the chat and I will try to address the issue. So what Dan advocated for was distributing naloxone to the people who were closest to the people at risk for overdose. And this is kind of one of the holes in the naloxone distribution under the healthcare plans that are set up right now in the US particularly, which are that to get something that's not over the counter like naloxone, you need to have a prescription for it. And what the prescription, strictly speaking, means is that you are using it on yourself, which for almost every other drug makes perfect sense. For naloxone, I wouldn't count on that. What you're really trying to do is to build up communities of people who can keep an eye on one another. And once we were able to train enough people in Chicago and distribute enough naloxone, we were actually able to demonstrate that overdose deaths were affected on a citywide level, even on a small scale of distribution like we had at the very beginning. And after that, Dan was sort of the advocate in the country for distributing naloxone. And I went to plenty of meetings with him, plenty of conferences, where one of the big events of every conference was when Dan gave the presentation on naloxone, he would bring 3 or 4 duffel bags full of naloxone and basically throw them open and ask who wanted to start a program. So there are plenty of naloxone distribution programs that got started that way. I think it's really easy to kind of look at these efforts with kind of rose-colored glasses. I will tell you that when I was working in Camden, New Jersey, we our program refused to distribute naloxone. So people I worked with and I distributed it under the table. And I lost my job for doing that. And I lost my job because a representative of the New Jersey Department of Public Health came and basically demanded that I be fired and my colleague be fired for distributing naloxone without, we were not prescribers. I was threatened with state and federal drug distribution charges. So I think it's really instructive to kind of look at things that look like they're really kind of out of bounds in terms of harm reduction right now. So Brooke was talking about safe supply being very controversial. It's not controversial that safe supply would reduce the number of overdoses. What's controversial is there are laws against ensuring a safe supply for people who are doing anything but using them for prescribed purposes. So, as Brooke said before, syringe distribution in Pennsylvania is illegal. I don't know how the programs are now. When I was working at Prevention Point Philadelphia, we worked, again, under the table with a lot of programs throughout the state that could not advertise their services because they would have been arrested. And so the reason that it's important to listen to people who use drugs is that there are risks that need to be taken that people with degrees and certifications and prescription powers and everything else, all the other trappings of professional life, all of those things militate against somebody doing the crazy stuff that I did and that other people have done in the history of harm reduction. So I think it's really important to look at the people who are using the services as the experts in the field, regardless of what professional certification someone might have.
Yeah, when it comes to safe consumption, Gus, it made me think of a conversation I just had yesterday. So part of my background is around peer support, training peer staff. I was one of the first certified recovery specialists in Pennsylvania when the credential first came out, and I didn't even know what it meant. It just sounded cool that I'd be certified in recovery, and so I was like, I'll get that. And I've done a lot around just like training, supervision, support of peer staff. And, I often would find myself at odds with what I was taught was appropriate for a certified recovery specialist versus what I knew was best as a peer to somebody currently using drugs. And the example I often think of is, I don't know about in your communities and in your counties, but in Philadelphia, accessing treatment can be a bit of an ordeal. And to stay well through that ordeal is hard, especially with fentanyl, right? Like people have to use more frequently. And so somebody would say, hey, Brooke, I really want to go into treatment, but I have to go get well first. And so I think, how I was raised up is, I would have said something like, if you really want help, then you want it now. You're not going to use another time. You must not really want to get better. I don't know if anyone ever heard that. Even if you were someone who said it, I don't judge you because that's what I was taught, right? Like, what do you mean you have to use one more time? Even though I knew I had to do it when I was seeking help. And then, if we moved a little bit down the spectrum from that, it'd be like, okay, I accept that you think you have to go get well in order to go get an assessment for treatment. Go handle that. and then come back when you're ready to go into treatment. And I think in a peer staff role in many organizations, that might be what you have to do, right? You're not, as a CRS, really supposed to go take someone to go cop. That is typically frowned upon, and so when we think about peer, true peer, when someone says, you know what, like, I want to go into treatment, but I know I need to get well to make it through the process. Last time I went, I wasn't able to stay because like everything in me was screaming, I need to get well. I need to get well. From a harm reduction perspective, the way we respond to that is, okay, let's go, get you well, whatever that includes, whether that means going to cop. And then also, I don't want you to die before you make it into treatment. And so rather than going into a Dunkin' Donuts bathroom or a Burger King bathroom or an alley or wherever, when you use, I want to be right there with you in case you overdose. So that way I have naloxone on me and we can make sure that you're safe. That would be the harm reduction way of doing it. So as a common scenario, I'm going to scroll down. How many of you have had somebody say, I want to go into treatment, but I have to go get well first? Just nod. Oh man, lots of you aren't showing your faces. I can't believe it. All right, well, I saw some hands. And so this is where we start to see some of the rub between harm reduction at its core and then what's expected, like Gus was talking about, when it comes to our credentials and our professional limitations. I always joke that if I make it on the front page of the Inquirer for getting caught up in a drug bust in Kensington, that I more likely than not was taking somebody, not in my professional role, just as a person, I have to put that disclaimer out there, that I was taking somebody to go get well, right? It's possible it could be me someday, but for the most part, it's taking someone to go get well so they can get what it is they need. And so we do have this tension, and it's not, I think we would need like a month-long series of all-day webinars on how do you navigate that. But it's just something to be aware of, that true harm reduction isn't constrained by credentials, by these boundaries that we see as people who use drugs supporting each other. And so we could try to get as close to that as we can, but we have to remember we have limitations as well. To be clear, I'm not advocating for CRSs to take people to cop and get well in their car. I know this is being recorded, but it's just something to think about the difference, right?
And also do not put it in any medical history.
Yeah. And did you talk about safe supply, Gus, at all?
Just as kind of what the fact that right now that seems sort of like the ragged edge of harm reduction to a lot of people. I think that it's instructive to remember that there was a time not too long ago when people thought about naloxone that way. When people thought about naloxone as encouraging drug use, or sort of covertly making the argument that if there's no risk of dying, who would stop using? Which I think is an argument that has a lot of moral problems, shall we say. Safe supply. So the idea behind safe supply is that instead of a replacement therapy, if I'm using cocaine, it might make sense for me to get pharmaceutical methamphetamines, at least in a perfect world, pharmaceutical cocaine. If I'm using heroin, maybe hydromorphone, Dilaudid, something along those lines, something injectable, and something that importantly is pharmaceutically produced to the point where I know what I am using. So that's what you don't get in an unregulated market, is that kind of FDA approval, for lack of a better way to put it. You really don't know what you're taking. And it's that uncertainty that makes using so dangerous to people. So what people in harm reduction are recommending, and some people, at least in Canada, there are some programs where they are prescribing hydromorphone, they are prescribing I have even seen recommendations for people in a lot of people who are using in Philadelphia right now are using fentanyl either knowingly or unknowingly, and that is what they're addicted to. I've seen people recommending distributing long-acting fentanyl patches as kind of a way to address that need without actually forcing someone to go out onto the corner buy something that may or may not be what you're looking for. So that's another thing to keep in mind around people talk about fentanyl a lot of times like it's something that is not desired. So it is illegal to distribute fentanyl tests, but there are some fentanyl tests being distributed. I can tell you there are people who are using those tests to confirm that there is fentanyl. They are looking for fentanyl. All right. So I come at that from a harm reduction standpoint, and as long as they're not overdosing every time they use, I am uninterested in the purpose that somebody's using a test, as long as the test is serving their needs and not mine.
It's funny. I think, when we talk about harm reduction, right, I think there's still some folks that see naloxone as condoning and supporting drug use and therefore not a good thing. There's this trope in the media that just won't die about Narcan parties. When, for people who use drugs, being Narcan is the last thing they want, right? And I don't know, for those of you who have had that experience, like, you're blowing my high and I'm going to feel like crap. Please don't Narcan me. And so we still do have some folks though, right, that are like, all this Narcan is enabling people to keep using drugs and is therefore like a moral hazard. And then, we see more people than not, I think, although it took time, who are like, okay, like, yes, like, naloxone saves lives. We want to get this, out into the community. Those are who are even more advanced say we want to get this into the hands of people who are closest to people who use drugs, not sitting, just in my car. But then we talk about safe consumption spaces, places where people are invited to come in and use drugs without risk of overdose death. Some of our folks who support naloxone distribution are like, wait, no. Now that is enabling. That is enabling. We can't have it, right? And then when we get to safe supply, that's really where, we still lose a lot of folks. The idea of having a safe, regulated drug supply or safer regulated drug supply, so that way people aren't experiencing the harms that are because of this forced, unregulated market. And the harm is not only being risk of drug poisoning deaths or overdose deaths, but also the violence, right? There is nothing to regulate the unregulated market except for violence. And so I know, the communities I work, that's also a huge, harm, right? The violence associated with that market. 40-minute, thank you, Tracy. That was great. I thought you were saying we only had 2 minutes and 50 seconds left, and I panicked because I only have one monster, and so I can't go that fast. But so these are sort of like, all ideas that came from people who use drugs. However, some more controversial still than others, and hopefully we see that change. Okay, so when we talk about equity in the era of the opioid epidemic, so everyone's heard that buzzword, right? Like the opioid epidemic. And so I am not invited anywhere to speak without raising the issue of this narrative that surrounds the opioid epidemic. And I apologize if you've heard me talk before and you're like, here she goes. But the opioid epidemic narrative, it goes something like this. And you all give some head nods if you've heard this, right? Little Johnny, like, kid from the burbs, played soccer, star of his team, never, ever, ever would he use drugs. He's not that kind of kid. He's not like those people, right? And then he was prescribed Percocet for wisdom tooth removal or, a soccer injury. He took them just as prescribed from his doctor. And then somehow he got hooked. And that is why little Johnny is now shooting dope. And, it's sort of this narrative of being like, duped into addiction, right? Very different than the narrative of the crack epidemic, where it was bad people who were doing bad things and we needed to just lock them all up like forever. And so there's a lot of problems with the narrative, and that would be a whole separate webinar. Maybe, Pit Peru and Vital Strategies will be like, Brooke, come back and talk about that. But, when we talk about equity in the era of the opioid epidemic, the reason I raise this is because, number one, we know that most overdose deaths are polysubstance events, which means that most people, like me, were using multiple drugs. It wasn't just opioids, right? And I don't know, for all of you on this webinar, like, I'm sure you see it, right? That it's not just opioids that people are using. It may be opioids and Xanax, or opioids and cocaine, or opioids and methamphetamine, or opioids and alcohol, or all of the above, depending on what was available and who hooked that person up with what that day. And so when we focus on just opioids, we're really missing out on what is happening, which is polysubstance use events that are causing tremendous harm. The other thing about the narrative that's problematic is that it's just not true. And I think when we lie to ourselves, that gets us nowhere fast, right? I know I learned that in recovery: honesty, open-mindedness, and willingness. And so when, year after year, SAMHSA puts out this national survey of drug use household something, did I get that right? It's a long acronym. It's like NASDA. But basically it's a survey that SAMHSA does and asks people about their drug use. I'm always amazed because if someone from the government called me up and was like, hey, Brooke, tell me about your drug use over the past year, I definitely wouldn't be participating in that conversation. So I don't know who they talk to. They never talk to me, but they talk to people. And what that data has shown us each year is that overwhelmingly people who used pharmaceutical opioids for the purpose of seeking pleasure or euphoria, otherwise known as getting high, that they got them from their friends, they stole them from their family, or got them from their family, or they bought them on the street, right? It isn't this story of the doctor prescribed them directly to the person. And so when we continue to have all of these prescription opioid focused conversations, policies, take back days, we're really not addressing the truth, which is that for most people who developed an opioid use disorder, number one, there were some risk factors or pre-existing things going on with that person that made them more susceptible to a substance use disorder than for, compared to the majority of people. It still blows my mind because I'm not one of them, but the majority of people who can use drugs and get up and go to work the next day, or they're not stealing tools from their dad in the garage, right? That's not most people. I know I was surrounded by the people who were stealing tools and not going to work, so it's still hard for me to wrap my mind around, but the data supports it. And so we have, and I try to name things what they are, this whitewash story of addiction where it's we would never use drugs knowingly. We were kind of tricked into using these prescription opioids, and that's how we got to where we are. It ignores all the risk factors, all the social determinants of health that leads to someone, being well versus unwell. And it just kind of, it creates a more deserving class of people who use drugs, and it's just not in line with what we know is going on. And the last point is really important. This opioid-only focus, the narrative, the policies, it just doesn't describe the reality of drug use for many people. And so while it is true that there are some people, a very small percentage, who developed an opioid use disorder because of, being prescribed opioids for pain, taking them as prescribed, becoming physically dependent, and then going on to develop an opioid use disorder, the reality for most is that many people were like me, where I just took them to get high, and I thought addiction would never happen to me. I wasn't, I was in control. I had it, whatever it might be. And then woke up and was like, wow, it happened to me. And there's also the reality of drug use for people who use stimulants, who use other drugs besides opioids. And so it's really important that when we think of equity in the era of the opioid epidemic, that we ask ourselves, is, the story that we tell one that reduces stigma for all people who use all drugs? Is the person who buys crack cocaine and uses it, is that person seen in the same light as someone who, is using opioids and was kind of tricked by big pharma and a shady doctor? And also, does it create services that are relevant for everybody? I don't know how many of you are in direct service, but if you try to walk somebody through accessing treatment who's using methamphetamine, is a very different experience than somebody who's using fentanyl. Fentanyl, I have to try to rouse the person to being awake enough to walk through the process. With methamphetamine, I have to convince the person that the shadow people don't go in assessment sites and that you'll be okay there. So it's just two different experiences. We know overdose deaths related to stimulant use are on the rise. And so when we think of equity, we really need to think about, people, all people who use all drugs, and that harm reduction does not just apply to opioids, and that we need to really be relevant for all people who are using drugs. Gus, if you want to add anything to that, I actually shortened my soapbox speech there.
Yeah,
Partially because
I mean,
Tracy held up the sign. I was like, we're running out of time.
I just kind of wanted to follow on what you were saying about stimulant use and point out that the level of acceptance for syringe access programs is way higher than the level of acceptance for the distribution of Pyrex pipes to vaporize crack or whatever else. From a public health standpoint, you can make the case that that is every bit as useful as distributing clean needles. It's easy to transmit. If people are sharing pipes, it's easy to transmit Hep C. And in terms of health outcomes and costs, Hep C and HIV are pretty close. So I just want people to think about, if you're comfortable with the idea of distributing syringes, are you also comfortable with the idea of distributing Pyrex pipes? And if you are, please feel free to contact me. I can tell you how to make that happen.
Thanks, Gus. Yeah, I think the key thing to remember too, if we go back to, I moved too fast for my mouth. If we go back to harm reduction as this broader social and political movement, and then harm reduction, as services, the larger political and social movement is very much focused, and always has been, around racialized drug policy, around the racist and classist war on drugs, where poor people and people of color have always been disproportionately targeted and punished for their drug use, despite using drugs at the same rate, and selling drugs, actually, the data suggests, at the same rate as people who are wealthier and white. And so it's kind of like, I think the clearest way I could say it is, if you're going to say, I support harm reduction, and I believe in harm reduction, always being aware that that means that you, in turn, are supporting, really the dismantling of, the racist and harmful and classist war on drugs. And it's not something that we get to sidestep. In fact, I think as we continue to center opioids and this narrative of addiction, we actually are causing more and more harm to people who use drugs, whether it's opioids or something else.
Yeah, and I think that's actually, Tracy, I noticed that some of the comments in the chat were around professional obligations and doing harm reduction, and how your licensure and legality and everything else interact. That's real. I have a lot of friends who are therapists who have a reporting obligation if they have a good reason to suspect that somebody engaged in sex work is under 18. Sometimes sort of the harm reduction way to deal with that is either to refer that person to somebody who is not under that obligation, or to lay it out with the person that you're working with, whether you're a prescriber or a therapist or whatever, and just say, before we go any further, I just want you to be aware of the legal obligations that I have, and I can't get around these. And this doesn't mean I don't like you and I don't support what you're doing. It means that I have to do this to keep working. So if you need to talk about this, I can refer you to somebody else, but we should really be careful about discussing these issues. That's one way to kind of go at it. I have a lot of empathy for people whose livelihoods rely on their ability to write prescriptions or their ability to deliver therapy or their ability to work with people who are both above and under the age of 18. There's nothing wrong with those obligations. You just need to be really upfront with the people that you're working with before things cross the line that you can't uncross. So I don't know if that addresses, I think it was Edward I was seeing that from, but anyone else who is kind of interested in those issues? Okay. So let's take a look at, so creating safe spaces for the inclusion of people who use drugs and specifically people who inject. So what this typically looks like in most programs is having focus groups or surveys. That may be necessary, particularly if users aren't represented on staff. It isn't sufficient, in my opinion anyway. You should certainly be doing that both explicitly and also just kind of talking with people and getting a sense of what the excuse me, what the lay of the land looks like where you are. So because I would say of the social and legal status of people who use drugs, the onus is on the organization providing services to take positive steps forward to provide support that is relevant to people who use drugs. And what that means is not just getting someone to nod when you say, I'm going to offer this service. It's allowing people who use drugs input into the policy and program design process as it's happening. It is really important to remember that, like Brooke said earlier, syringe distribution, even back in the days when it was called syringe exchange, that didn't happen because somebody with an MPH or a DPH crunched the numbers and decided that was the best approach. That happened because the people who were using syringes, and this is true in Philadelphia, it's true in Chicago, it's true in most places where the sort of first generation of syringe programs started, they were started by people who were using, and they were just as far outside the realm of what was acceptable, like I said earlier, as naloxone was around 2008 or 2009, or as I would say safe supply is right now. So it's really important when you're working with a population under, engaged in the gray economy, trying to support themselves in any way they can, whether that means getting enough money to get a habit or getting enough money to be able to buy a place on somebody's couch at the end of the day. You never know what people are sort of on the hustle for. And the key to harm reduction isn't trying to design the survey that will elucidate that information most directly. It is your ability as an employee to form respectful relationships with the people who have the information that you need. This is the point in the presentation where I point out I have a bachelor's in German literature. Okay. I know a lot about public health. I do not have any certification in public health. What I have learned about injection drug use, what I've learned about smoking, what I've learned about vaping, what I've learned about snorting, what I've learned about everything, I have learned because I can build respectful relationships with people, because everything I know, I have learned from the people who are engaged in those behaviors. And you will know you're succeeding when you don't have to ask questions, when you have built a relationship to the point where somebody's sort of guard comes down. And that's a big moment, because remember, people are talking about illegal activities. And like Edward said earlier, some professionals have professional obligations when they're confronted with evidence of an illegal activity. So if you get to the point where somebody feels comfortable talking to you about something, whether you're in that professional situation or not, take it for the gift that it is. Because what the person who has that information has overcome is what's in this next sort of bullet point: understanding how oppression and marginalization influence interactions with people who use drugs. I personally don't have a history of injection drug use. I have been run out of supermarkets because security thought I was. I have been forbidden entrance into a building because somebody thought I was using. When you're working with people who are in these marginalized communities, drug use, sex work, whatever, be sure to try at least to put yourself in their place, and keep in mind that if I don't have an income, I'm homeless, and I lose my ID, getting a new ID can be a very challenging process. So if I am in a building that requires photo ID to gain entrance, and there are a lot of them now, understand that that will limit the number of people that you can work with. And the other sort of obligation you have is, as you're designing programs and funding them, you have to make sure that you are not writing checks that your program can't cash. You have to, going back to the point where the goals of a program get out of line with the needs of the people using that program. This is often where that happens. When you let, and I don't know if we have law enforcement personnel here with us today or not, but I would say a lot of the harm around injection drug use comes from the legal status of the drugs, and in Pennsylvania of injection. I don't know how appropriate it is to allow law enforcement programmatic input into a syringe access program, into a methadone program, into any kind of harm reduction intervention. If I were ever able to start a safer supply program and the police said, well, we are going to have to tell you how to do that, I would not, as much as I want there to be a safer supply program in Philadelphia, I would not start a program under those auspices. So you have to recognize not just the constraints that the legal position of injection drug use puts injectors in, realize that you are also subject to the same kind of restrictions, like I talked about earlier, and also around program design and funding sources. It's really important to not get funding from a place that's going to be very upset when they discover what it is you're doing. You have to be very open about that. And if you lose funding because of that, you lose funding because of that. And that's a hard thing to say in the nonprofit world, but you have to decide whether getting money to start any program is better than waiting or having a lemonade sale to fund the program that you think will actually work.
My bad on this slide. I was trying to type in the chat and I kept moving slides. So if anyone got dizzy, I apologize. I know we have like one leave time for questions and answers, so we'll kind of move quickly through the next couple of slides.
Yeah. Okay, so yeah, this is just often when people consult with drug users, homeless folk, sex workers, the way that it's done is you have a listening session. The program will buy a couple of pizzas and some soda and consider that adequate compensation. You are asking people who have information you are not able to get from anywhere else to help you make your program more effective. People who do that need to be compensated at the same level that you would compensate any other professional for their knowledge. You know, I'm not a lawyer. If I need a lawyer, I expect to pay that lawyer. There is no excuse for not paying people who use drugs in cash for their knowledge, because it's really not easy information to get, and it relies not just on the person who has the information, but on your ability to support them to the point where they feel like they can share the information with you. You do also have to think about things like meeting structures and times. So if my hustle is standing at an exit ramp for a big road at rush hour and getting change from the people who are waiting for the light there, I need to be able to do that during rush hour. So scheduling a meeting at 6 p.m. means I will not be able to be there. And so one of the things you should be able to do, thanks, Tracy, is to understand the constraints that people are working under. I don't know how things are in other parts of the state. One of the things that's always freaked me out a little about social service delivery in Philadelphia is it happens Monday through Friday, 9 to 4 p.m. You know, like people's problems only happen during office hours. That's not how it works. Also, be certain that in no way you are making any service or material you're supplying contingent on somebody engaging with you around program design and other modes of accessing the knowledge that the population you're working with has. That is a barrier to services, and one of the keys to harm reduction is reducing the number of barriers between a person and the services that they determine they need.
It reminds me, Gus, there was one time when I was working for the city and was charged with doing focus groups with people who currently use drugs or were sort of like, early in recovery. So, very close to what it's like to be a person who's using drugs today. And I went to one methadone clinic in Philly to conduct a focus group. And that clinic decided to basically withhold dosing for the people who were asked to participate in the focus group until after they participated in a focus group. And I was wondering why everybody looked so mad and anxious and like they hated having to be there. I think I'm pretty fun to be around and wasn't used to that response. And I couldn't believe that this program did that. And I actually ended the focus group and then, talked with the executive director about how not okay that was. And so that's a pretty, egregious example of making services contingent on participation, but it does happen. And the other thing I want to add too is I've been thinking about this a lot, especially as Gus and I have talked about this content. As a consultant, I got to fly around the country, stay in hotels that I never would be able to afford myself, and was basically paid a lot of money to tell people what I think, which I'm still baffled to this day that somebody decided to pay me to talk, but it happens. It's happening today apparently, and we'd be paid like $1,000 a day for me to just talk and to give my thoughts, my insights, my, whatever. And then when we ask people who use drugs to give us their thoughts and their insights, we're like, here's a couple tokens, a slice of pizza, and like maybe a gift card to like Rite Aid or something so you can buy personal hygiene products because we don't trust you with cash. Never as a consultant would I have been paid, it never was like a funder like, we're going to go ahead and send that money to Verizon to make sure you pay your bill. I got paid in money, right? And why is that different? In fact, in some of those spaces, I was not the person that should be there giving any kind of opinion or insight because I'm 15 years away from, currently using drugs or engaging in the illicit market. So certainly challenge yourself to think, how would I compensate a subject matter expert when you are in fact engaging a subject matter expert to inform what you're doing?
It's also one experience I had at Prevention Point, Brooke, is we had somebody come in and use Rite Aid cards as compensation. And what we then immediately discovered was that nobody who used Prevention Point was actually permitted to go into the Rite Aid that was by Prevention Point. Every one of them had been banned for whatever reason, but I ended up compensating people for cards they couldn't use because, and that's something, it's difficult to kind of ferret that out. It's often the case that there are programmatic obligations to use gift cards. Just understand that when you do, something like that can happen, which means like not only is that a strain on the people getting the gift cards, but I don't want to sound too selfish here, it was a strain on me. As an employee of the program, I all of a sudden had a pay period where a big part of my check ended up going to people $25 at a time because I could use those cards and they couldn't.
Mm-hmm. Yeah, and the meeting structure thing, we think about what's expected meeting engagement and behavior, right? For those of us who are in professional roles, to lay those expectations on people who are currently using drugs or who aren't social workers or case managers or certified recovery specialists, that's definitely not going to help when it comes to engaging people who use drugs. So even things like expecting a prompt response to an email, or that people are even on like these like distribution lists where there's an announcement of a meeting, and then the meeting happens and it's like, well, we invited people, they just didn't come. Think about how you're communicating with folks, and then also how the meeting is run. Expecting the same kind of behaviors that have been deemed professional meeting behaviors is maybe not the way to go, right? And if someone
Yeah.
needs to get up and leave and come back, and it just may look very different. And meeting people where they're at includes how we're engaging and meeting with people to get their thoughts. So I think with protections and considerations, I know we're kind of running short on time. So if you want to go through this, Gus, and then we're close to the Q&A section, which I always hate when it's limited time, but.
Right. So, yeah, just rushing through this real quick. Law enforcement experiences, disparities in law enforcement experiences, that's really tied up, certainly in Philadelphia, with race. I can share an experience I had in Chicago where we had a group of youth who were meeting, and they would move the meeting around, and somebody offered one day to have the meeting at their house, and they had a nice big open space. And so I distributed the address. Everyone went, and what happened was the house was in the Chicago equivalent of the Northeast or Grace Ferry, so where all the cops in Chicago lived, or at least half the cops. And it turned out that none of the African-American participants felt anywhere near safe going to a meeting in that neighborhood. So we had to kind of adjust that. Those kind of things are sort of real things that can happen, but also echo the sort of larger programmatic issues. It's really important to remember when you're working with drug use that the illegality of drugs is essentially tied to racial identity. For every illegal drug, you can trace back and find out which racial group it is they were trying to hassle when this drug was made illegal. So it's really important when you're considering the legal status of a drug to remember that it's not like this was some dispassionate, rational process. You know, this was very visceral and very racial. You have to have a good sense about how much protection you can provide. I really want to make sure nobody gets arrested here in Philly and Kensington. I can't stop 4 squad cars coming from 4 different directions, rolling up on somebody and taking them away. I'm just not a ninja, you know. It's important to understand and we talked earlier about professional limitations, also just real life limitations about what kinds of protection you can provide. And do keep in mind how legally precarious the situation of being a person who uses illicit drugs is in our society. And do not expect people to be heroes. Okay. So
I think with this last slide, we talked a little bit about just the importance of building relationships, right, Gus? And just, I think focusing on building respectful relationships, which takes time, right? Like to build trust, to establish rapport, and to really center the experience of people who use drugs, even if it conflicts with what we think we know or what we think we read. If someone's telling you this is their experience, then really valuing and centering that. And at the same time, understanding that like real world experience in real time can sometimes conflict with, the research that's available. We know there's a huge gap between research and actual practice. And so, taking care not to dismiss somebody's experience. I see this with BUP a lot, actually. Getting onto BUP, initiating BUP is different with fentanyl than it was with heroin. And sometimes, we're expecting the same thing, and we don't have as much literature around what BUP initiation with fentanyl is like, and we're basing, practice on some outdated information. And then I would say to all of us, right, also understanding that real-time experience today for people who use drugs is very often different than what our experience was when we were using drugs. And that's for my abstinence-based peers and friends in the room. You know, I go back to, again, I could buy pills on the street and know I was getting a Perk 30 or an Oxycontin, whereas today, you know, you're likely to get pressed fentanyl and none of what you think you're buying. And so it's human nature to kind of apply our experience as universal and to everybody. But I know for me, what's worked as a harm reductionist is some humility that what my experience was and what I think I know may conflict with what other people's experiences are, and what the reality is today. And so as always happens, whether you're on Zoom or not, we have left 3 minutes for Q&A. And so I don't know, Tracy, if you saw, I tried to keep up with the chat, but I just am not that talented. If there's any questions that popped up.
You actually did an excellent job of keeping up with the chat, I think. So I know folks may not be familiar with the chat, so if you could raise your hand with the raise hand icon, we could also do it that way real quickly. Maybe one question, a final question. And Lakin, can you put the final slide with resources and follow-up on? What are some good resources for me to find literature regarding harm reduction?
I mean, there are some, honestly, and again, like I started doing harm reduction in Chicago while I was working at the University of Chicago. So my start was one of my students giving me a 4-page annotated bibliography of harm reduction. That's an unusual experience. I would say, so for the history of kind of the interaction of law and pharmacy, there's a book written by, does anyone from Pittsburgh know Caroline Acker? She was one of the founders of Prevention Point Pittsburgh. I think she's still on faculty at Carnegie Mellon. I'm not positive. She wrote a book called Creating the American Junkie. It's about 10 years old now, maybe a little older. That's really good. That's a great sort of introduction to the way that we came from being able to buy heroin in the Sears catalog along with the syringes to use it to where we are today. That's a really interesting and I think vital story.
Yeah, and actually some folks had some great suggestions in the chat. I saw Chasing the Scream came up and I thought that was a pretty,
Yeah, that's good.
I was able to read that during grad school, and so that says everything about it being easy to digest because I was so sick of reading. So Chasing the Scream is a great book. I know Joy suggested Coming to Harm Reduction, Kicking and Screaming, the National Harm Reduction Coalition website, Drug Policy Alliance, but we can certainly work on kind of compiling some resources.
I would say also just, you know, there are online threads of people who are using drugs, and you can get a pretty good sense of the issues that people are facing currently. Now, they may not be the ones that are in your neighborhood, but that's one way to do it. What other? We can, why don't, Tracy, how about if we look for some resources and you send them out afterwards?
That sounds great.
Okay.
With that, I think we are at the end of time. So thank you, everybody, for participating in our first webinar of our upcoming webinar series. We will be posting and sharing the dates and times for future webinars. In the meantime, please fill out your evaluation forms and feel free to contact us if you have any other questions.
Thank you, everybody.
Thank you.
Thanks, everyone.